Well, welcome. We're excited to have everyone join us virtually. My name's Jacob Jones, and I'll be focusing today on evaluating adolescent ankle pain, especially in regards to injuries. So let's get started. I have no disclosures in regards to this talk. So we're going to talk a little bit about the anatomy and how it relates to ankle injuries. Then we're going to describe some physical exam maneuvers, and then we're going to demonstrate some of those via videos. All right, so first, let's talk about the anatomy. We're going to start by looking at the lateral ankle. Some of this you may not have thought about since medical school, but we're going to hit just some of the basics, all right? So first, this ligament right here, outlined with the blue arrow, that's your anterior talofibular ligament, or ATFL. The nice thing about the ligaments in the ankle is they tell you what they connect. All right, we're going to move clockwise. And this one in the orange is the calcaneofibular ligament, or CFL for short. And then on the back side is the posterior talofibular ligament, or PTFL. Now we're going to jump over to the medial ankle. There are lots of ligaments on the medial aspect, but we like to group them together into one single ligament complex. We call it the deltoid ligament. So this whole ligament complex is the deltoid ligament. Then over the posterior aspect of the ligament, the main area of concern is this guy, which is the Achilles tendon, which connects the calf muscles down to the calcaneus, which is the heel bone. All right. And then we're going to move over to the anterior ankle here. We're going to focus on ligaments that make up the high ankle, or the more upper part of the ankle. And the blue arrow here points towards these ligaments that connects the tibia to the fibula. We call it the ankle syndesmosis. There's some other small ligaments in this area as well, but we kind of group them together into the upper ankle ligaments for short. All right, so with any type of ankle injury or ankle pain, history is a vital aspect. All right, so I think there's two key things to make sure you get with the history. First, was there an injury that occurred? And then second, if there was an injury, can you have them recreate the injury? Sometimes in our adolescents or even younger populations, they can't always say what happened, but oftentimes they can say, oh, my ankle went this way. And they can maybe demonstrate with their injured ankle or their other injured ankle, or maybe they'll demonstrate with their hand a little bit. So like the picture seen here is like, oh, my ankle rolled, which in this instance was an inversion type ankle injury. It's important because that can really help us zone in on our physical exam and help us with our diagnosis, evaluation, and treatment later on. All right, so first part is inspection. All right, so here we're going to make sure we're looking at all aspects of the ankle. All right, we want to make sure that there's no breaks in the skin, bruising, swelling, erythema, deformity. Those are the things we're looking for. And remember, with the ankle is very gravity dependent. So sometimes if you're seeing them a little bit further out, the area of swelling or bruising may be away from where the actual injury occurred. All right, so we looked at the lateral ankle. Now we're going to make sure we get a good look at the medial aspect of the ankle for these same things. And then I like to have the patient stand if they're able to stand. Not only do you get a view of their entire lower extremity, but you can get a view of their overall alignment. So I'm going to look at their knees, which way are their knees facing, which can give us an idea of how their alignment is. And then the second thing, as you can see with these lines drawn, as you can see, is there any type of curvature to their lower extremities, which may play a role in their pain or may have been a contributing factor to their actual injury. And then I'll have them turn around. I'll look at them from the posterior aspect as well. Once again, I can look at alignment, and then I'm going to pay particular attention to the lower aspect to see what their alignment looks like down low. So I can see, yeah, is there any type of curvature or angulation of their heel that may also contribute to their pain or their injury. All right. And then another area I want to look at is I want to look at their arches. Okay. So you can look at a little bit from the back. Sometimes I like to look at it from this angle, And I'm going to pay close attention to that arch there. Where you can see that red line there. Is it flat? Do they have some pes planus, or do they have a high arch like a cavus foot that may be contributing to their pain that they're having, or contribute to their injury? Next is I like to have them do some active range of motion. All right. I'll typically have them move in circles one way, and then I'll have them flip and do circles the other way. And then I'll have them move in each particular plane. So I'll have them dorsiflex up, then I'll have them plantar flex down. I'll have them internally rotate or invert a little bit, and then externally rotate as well a little bit, and then move their toes as well. I'm checking to see, hey, are the muscles and tendons firing appropriately or not? All right, then I like to do a neurovascular check after that. So I'll usually check the dorsal aspect of the midfoot, check for a pulse over the dorsalis pedis, and then just posterior to the medial malleolus, I'll check for the posterior tibialis pulse as well to make sure that everything's intact there. I can do a quick neuro check by checking sensation as well, the distal aspect of the foot to make sure everything is intact there as well. All right, so after those beginning steps, we're going to get into palpation. I actually think palpation is key. Once again, if you can remember those basics of anatomy, and then you can palpate over those areas and they say, yeah, I hurt right over this area, that can help you zero in a little bit on, what should I x-ray or what could be going on with this patient. All right, so let's look at what we do here. So I make sure I'm systematic in this approach, and with every ankle injury, I do it the same way. I like to start at the very top, okay, just below the knee, and then I'll slowly work my way down. And what I'm doing here is I'm squeezing. As I'm squeezing, it helps me palpate between the tibia and the fibula, all right, to see if there's potential injuries in that area. And it also helps me do a special test, which we'll address later. And if there's ever any question, like what particular area they're most painful, I can always go back and palpate that area again. So after I squeeze down, I palpate over the anterior aspect of the ankle, and this is about the area of the anterior ankle joint. And then I'll move medial with my thumb. I'll palpate over the medial malleolus and then around it where that area of the deltoid ligament is. Then you can see I'm going lateral, hit the lateral malleolus, and then around it. All right. And then once again, think about your anatomy. I'm going to palpate over those particular ligaments that I know are there. So there's the ATFL. I'm pushing over there, see if there's any type of pain. I don't have to ask them. Sometimes I just look at the patient's face while I'm palpating. And then I'll go right below where that CFL is while looking at the patient's face. And then posterior as well, where that PTFL is. All right. So after I'm confident I've got the lateral ankle down, I'll go down into the medial, over the midfoot and kind of palpate all over the foot as well. Make sure they don't have any pain down in this area. All right. If they do have some pain, it may help tell me, oh, I need to get some x-rays of the foot as well. Perhaps they have an injury that occurred down here. And after that, I'll go to the posterior aspect. You can see me squeezing there, the Achilles tendon, and then I'll go down to the calcaneus. And I'll give a good squeeze to that calcaneus as well to make sure that there's no pain or any potential for injury in that area. This shows you the medial aspect, so you can see I palpated it before, but just so you see medial malleolus, and then after I palpate on the bone, I'll go around the bone where that deltoid ligament is to make sure I'm confident that I got the whole thing palpated. All right. So once again, palpation I think is big. I think that really helps guide my treatment, guide my x-rays. And then when I get the x-rays, I can zero in on particular areas after I took a whole view to say, is there anything in this area? Because that's where they were having pain. All right, so here's just some drawings of the anatomy overlying the different areas of the ankle. So you see the green here, the bones, see that lateral malleolus and the red ligaments. All right, then review, go over to the medial aspect of the ankle. See the medial malleolus in green. That red ligament is the deltoid ligament. So when I'm palpating, that's what I'm thinking about. And the posterior ankle. So the orange there outlines the distal aspect of the calf into the Achilles tendon as it attaches down onto that calcaneus in green. All right. So you're good with palpation. All right. Now after that, we're going to go on to demonstrate some of the special maneuvers. Here's a list of the special maneuvers. and other things that we're going to evaluate with, all right? So first is the anterior drawer test, all right? So let's see how we do this. First, I take my non-dominant hand and I get a good firm grip on the lower leg, all right? This is important because you want that leg to be firm. You don't want that leg to move, and you're going to be providing some counter traction with that hand and with that non-dominant arm there, okay? And then with my dominant hand, there's two ways you can do it. You can either cup the heel, as you see here, and kind of use your fingers to go all around the aspect of that heel. And then once you get a firm grip, I'm going to try to move that ankle anteriorly. All right, so I'm going to try to move without the foot flexing too much. And I'm feeling more than I'm looking for an endpoint. I want to feel how much that ankle moves anteriorly. And I want to feel, is there a strong endpoint when the ATFL ligament becomes taut or not? This other method I'm showing you is the preferred method for me. I like to kind of wrap my thumb over the anterior aspect of the ankle, which gives me a little bit firmer grip, a little bit more control. And then once again, I'm moving that ankle anteriorly. And I'm feeling, you can see a little bit there, like, yeah, he hits, or I hit a good firm endpoint when the ankle suddenly will stop, okay? A key part of these exams is always check the contralateral side with ankles. These patients have another ankle, so I want to see, hey, what's their baseline like? Are they naturally a little bit loose, or is the other ankle a lot tighter where they don't have as much movement as they do on this injured ankle, which can tell me this ligament is either injured and or it's not functioning the way it should be. All right. So once again, let's review the anatomy of this ankle exam. Okay, so what we're trying to do is we're trying to separate the lower aspect of the ankle, outlined here in orange, with the upper aspect of the ankle, outlined in green. And we're doing that by moving the ankle anteriorly. So with that in mind, you can remember, or you can imagine that the ligament that's going to be stressed here is going to be the ATFL, which you can see there with the blue arrow. All right, so we're good on the anterior drawer test. Now we're going to go to the Talar tilt or stress inversion test. All right, so with this exam, once again, I'm going to get a firm grip of the lower leg there to make sure that that does not move. Then with my other hand, I'm not going to grab the toes, but I'm actually going to move up and I'm going to make sure I get a good full grip of that whole foot, all right? And then I'm going to invert it. I'm going to slowly tilt it, right? Because this is the left ankle in a clockwise motion there. And you can imagine as I'm doing that, what area of the ankle is going to be stressed, right? Well, if you remember your anatomy, those basics of the anatomy, that's really going to stress these lateral ankle ligaments, okay? And then once again, you can tilt it the other way if you want to stress the medial ankle ligaments a little bit. All right. All right, let's move on to the next test, which is the Thompson test, okay? And this is to evaluate for an Achilles tendon injury. So what we do here is we have the patient lay prone on the exam table. You can see both feet are dangling off the edge and she's relaxed or comfortable. And I'm going to simply squeeze that calf muscle, all right? And as I squeeze, I'm looking to see if the foot is going to plantar flex a little bit. If it does, it tells me, hey, the connection between that calf muscle and the foot, which is the Achilles tendon, is intact. And once again, you always want to compare it to the other side. If there's any concern saying, hey, this one isn't moving very well, or it's not moving at all, check the other side as well. All right. So to review our anatomy, you see the posterior ankle, there's our Achilles tendon, right? When the calf muscles contract, when they do what they're supposed to, it causes the Achilles tendon to pull that calcaneus upward, right? Which in turn causes the foot to go plantar flexed or to move downward a little bit, right? And so if there's some type of disruption in that connection due to a tear of the Achilles tendon, then things are not going to work quite as they're supposed to work. And that's going to tell you that you have a positive test. All right. So let's move on to the next one, which is the squeeze test. which evaluates for a high ankle injury. All right. And this is the one that I combine often with my palpation test. All right. So what I'm going to do is I'm going to squeeze at the upper aspect of the tibia and fibula. I'm trying to squeeze those two bones together. All right. I'll kind of work my way down a little bit and squeeze in different areas. And what I'm looking for when I squeeze is you see if there's a little bit more movement in the distal aspect of the tibia and fibula, or more commonly is that they have pain in that area. Okay. So understanding the anatomy, you can understand that if I squeeze at the upper part of the leg, it's going to cause the lower part of this leg to try to spread apart, to try to go apart. And then if there's some type of injury in this area, you can imagine how either there's going to be more movement or more commonly there's going to be more pain, and they're going to point to that area as far as where they're having the pain. Okay, so that's the squeeze test. Next one is external rotation testing. All right, so with this, once again, first step, I'm going to make sure I have a good grip of that lower extremity. I want to keep that leg, that lower leg, nice and stable there. Okay. Then with my other hand, I'm going to take the palm of my hand, and I'm just going to externally rotate her foot for her. I'm going to have her relax, make sure the patient is relaxed, and then kind of push outward. Once again, I'm looking for pain, and I'm going to see if there's a little bit more movement. All right, and this tests a high ankle injury. So right where I was pointing there is the area of pain where I'm looking. So let's go to the anatomy. As I externally rotate that ankle, the talus is going to try to move apart the tibia and the fibula. All right, and so if there's an injury to the high ankle, it's going to cause that part or the high ankle area to have some pain or to try to move apart. All right, so we're good there. So after those special tests, the next thing I like to do is I do range of motion testing, resistive range of motion testing. All right, so this helps me test strength particularly. So I want to see how strong they are, and if I'm trying to getting back to sport, are they ready to get back? So I'll have them invert, have them, evert or externally rotate a little bit, and I'll push against them. I'll have them plantar flex as well, and then I'll have them dorsiflex as well. And the entire time they're doing it, I'm resisting them and seeing how strong they are. And then once again, you can compare it to the other side to see how strong they are compared to the other ankle. It's always important to do gait testing. In COVID times, we're limited to the rooms. It's nice to see them a little bit longer distance if you have a longer hallway. But I'm seeing if they have any type of limp. I can also see their alignment and their cadence as they walk back and forth in the room. Sometimes it's good to try to distract them because they stay a little bit focused on how they're walking. All right, after this, I'll do some double and single leg toe raise testing. This tests their strength and how their pain is in regards to their strength. All right, so I'll have them go up on their toes. So I'll usually do both feet first and see, all right, are they able to do this or not? This tells me how strong and how confident they are on their ankles. All right, and then after that, I'll have them do a single leg toe raise. I'll have them do it both on the injured side and on the uninjured side. All right. This tells me, and it tells the patient as well, gives us both a little confidence saying, hey, you are injured, like you're not ready to get back to your activities yet. Or on the flip side, like, hey, look, your ankle's pretty strong. Like you're in a good situation. You can start getting back to your activity or start getting back to sport a little bit. So that's one of the main things I like about this aspect of the exam. All right, so we've talked a lot about different aspects of the exam, the importance, and their relation to anatomy. I've gotten feedback before that people like little tidbits about things they can take home and apply immediately to their practice. So here's one in regards to x-rays. These are probably the standard x-rays I obtain if there's an ankle injury. So if you're going to get some type of x-rays because you're concerned from an ankle injury, these are some good standard ones to get if you're not quite sure what to get. So anterior one, you can see the anterior aspect of the joint pretty well there. This one is called the mortise view. It's just slightly angled. I like it because I can see the lateral malleolus at a different view to see if there's any injury there. But I can also see the joint between the talus and the tibia and fibula well, as outlined here by this red line. You see that? How well you can see that joint outlined. All right, and then you can also see the area of the high ankle without any bony overlap. All right. And then, of course, I get the lateral view, which you can see the posterior aspect of the ankle and the calcaneus really well on this view. Well, thanks so much for your time and attention as we went over the ankle exam. We're working on distributing a quick reference sheet that went over some of these aspects and has just some tidbits as far as treatment goes. Thanks so much.